Good evening, everyone. This is Meldita, and I'm back. So this is non-STEMI versus STEMI, part 3. Post-PCI potential problems. These are immediate problems. We have bleeding, vasovagal, instant restenosis or infarction. I am discussing today bleeding and vasovagal. The friendly findings, this will happen later. We have here troponin washout, the benign arrhythmias, or the reperfusions. So also we will be utilizing here nursing approach. That includes the assessment, head to toe, all the systems in here from neuro, pulmonary, cardiac, GI, and GU. Gastrointestinal or genitourinary. History, what happens before going to the cath lab, during the cath lab, and en route to CCU. The vital signs, you include also the patient is already on continuous cardiac monitoring, pulses checks, their temperature, sensation, color, problems identified or need identified, what's your plan, what you're gonna do, intervention, and did it work? Okay, so there are two approaches in doing stent insertion in the cath lab. I mentioned to you before, via radial artery, that one, or femoral artery, okay? So after PCI or stent insertion, the interventionalist will utilize arterial closure devices. One, radial approach, the doctor will use the wristband or the transradial band in here. They inject air, a total of 15, sometimes 16 cc's of air. This is the syringe because we're gonna be deflating soon once we discontinue this one. And then this is the most common approach post-procedure to achieve hemostasis, the TR band. The most common among these femoral closure devices is perclose. So the doctor will use a special kind of suture in here because they cut the whole wall of the femoral artery in here. So they have to suture back in here. So that's the suture and it is absorbable. And they also use angioseal. So this is the most common perclose. Angioseal, they make use of a collagen plug. So this is absorbable. This is absorbable. This is a collagen plug. So I compare this like toothpaste, okay? And there is also, when the patient comes back, rare cases, we get a patient with arterial sheath because now we'll be dealing with its removal and clamp application and clamp removal. Okay. So there are two patients here with different sites. So with radial band or transradial band removal, usually the cath lab nurse will tell you how much heparin was given, the time the procedure was finished, radial band, how much cc of air is injected, and if the patient comes back with arterial sheath in situ. For nurses that are receiving this patient from the cath lab, we hook the patient right away to the cardiac monitor, so continuous monitoring, watching all these rhythm problems. There is an IV going, the site should be good, and it's not interstitial because if something happened, blood pressure drops, especially vasovagal, we have, the site is already ready. Okay, so be sure that we have good sites. Sometimes I prefer 2 sites. I do put in 1 extra just in case. Frequent checks, okay, especially neuro and cardiac, vasovagal, they happen so quick. But I did say they all happen, they always happen, no. At times it will happen, it possibly will happen. Also vital signs, your oxygen saturation, and your vascular checks, your pulses, from a scale of 1 to 3, 1 is the least and 3 is the best. Your color, is it cyanotic, mottled, or what? Your temperature, is it cool or what? Sensation. This will tell us if there is a clot sitting in the artery that will affect, the perfusion of the site, or sometimes if the TR band is too tight, that could affect as well. So just to be sure, because the patient will complain of some discomfort. So just to be sure that it's not too tight or whatever, but the doctor in the cath lab is good. They know what they're doing. So patients are actually okay. But in the event, especially if they're developing hematoma, then that thing will get tighter. Okay, so that's a different story. Okay, so if the patient comes back after stent insertion or percutaneous coronary intervention, the first release happens 90 minutes after the procedure, and then 2 cc's of air is released every 15 minutes. It takes a total of 5 to 6 clicks, dressing applied, and then everything is okay. if the patient is bleeding after after you did that procedure, you can actually apply, your one hand with all your firm fingers pressing on the side. And if everything's okay, let's say maybe 15-20 minutes, you just have to chest and raise. You always use clamp, of course. It's always okay. Then be sure you have your gloves, your dressing and everything. You press on it. After probably 15 minutes, you reapply new dressing again, and that's it. Okay. So what if there's hematoma? That's different story. You use the knuckles of your hand. This is it. They're better, and then you less fatigue. You last longer with this kind of maneuver. Okay. What if this is a STEMI and they found that it's secondary to vasospasm? So they just did angiogram. They didn't find anything, but probably there's a spasm, but you have ST elevation. So what they're gonna do here now is the first release will be 30 minutes after procedure. 2 cc's of air will be released every 15 minutes. It takes 5 to 6 clicks again, dressing, and if bleeding happens, you do the same maneuver as I mentioned earlier. Okay. What if we will remove the arterial sheath and apply clamp? Okay. This is the next topic that we have to do. Again, the cath lab nurse will tell you how much heparin was given. Now, if in the event that this patient was given protamine sulfate, remember that heparin's half-life is 1 to 2 hours. If you have, protamine sulfate, which is a heparin antagonist, usually it takes, the half-life of heparin is about 30 minutes. So they will tell you, you can pull the line after 30 minutes. Okay. So you get all the information. Again, hook the patient to the monitor. Everything is done just like the radial approach here, in terms of these checks. Here we go. So the cath lab nurse will tell you what time can you remove the arterial sheath. And if she said so, you follow that and you have the clamp ready. You actually have everything ready on your hand before you do this procedure. You got everything. Be sure that your bag is full. Normal saline is full bag. You got, your atropine. You got everything that you need just in case anything happens. Vasovagal, because it will cause pain. Okay. So once after, let's say, you can remove the patient's arterial sheath at 9 o'clock in the morning. Then you wait for 10 minutes. You start actually releasing or loosening the clamp. So there's a loosening thing on top, and you can loosen per protocol. It could be half counterclockwise, or it could be full clockwise or counterclockwise, whatever, because you're going to loosen it. Okay. So after that, after 10 minutes, you start loosening the clamp, and then you can do so the rest every 5 minutes until it is okay. Be sure that your checks and everything is always done, your pulses. For the radial approach, you will be using actually your radial pulse and ulnar pulses. But for your femoral, you'll be using your dorsalis pedis and your posterior tibialis pulses for pulses check. Okay? And if bleeding happens for the femoral, all you have to do is after the procedure is okay and you think, fine, everything is okay, I did a good job. Well, that's good. So here we go. Then suddenly the patient rang the bell and said, I'm warm, I am wet. Okay, you notice the groin is bleeding. So all you have to do, if it's external, just put on your gloves, put a thick dress, remove that, dressing there, and you press it. But be sure that you can either use 2 hands with firm fingers, or a huge patient needs actually both hands using your knuckles because you last longer. Okay. So if the patient